Hey everybody, it's Kelly. Welcome back to the You Are Not Broken podcast. Happy January 2023. Happy New Year's. Um, I'm so glad that you're here. Shout out to my fans in the Midwest, specifically all of y'all who are like freezing in the Midwest because it's winter. It's like 55 degrees in the Pacific Northwest right now. I went on a walk this morning with my hubby and my puppy. And I have a lot to talk to you guys about, so I'm excited to be here, and I've got coffee. And just a reminder, this is not individual medical advice. You know that. This is for education and entertainment purposes only. January live podcast. Bringing in some of my members to the live recording right now. Welcome, guys. The first thing I'm going to talk about, if you guys don't follow these two people, Vanessa and Xander Marin, they're very big on social media. Because they're so big, they can like interview all, or they can poll all of their people, and they polled 54,000 people, and they emailed out to their email list, if you don't follow them, a sexual frequency report. If you want to hear me interview them, go to the podcast number 181, Sex Talks with Social Media's Sex Educators. So Vanessa Marin is a sex therapist, and her husband Xander is part of their new team on basically sex education. So it's cool. I'm going to read their sexual frequency report because this is how they polled everybody, and it's got some cool things. So they asked, what's your current frequency of sex? The majority of them it was kind of tied. It was tied. The two biggest frequencies were 2 to 3 times a week, coming in at 26%, 1 time a week, coming in at 23%, 2 to 3 times a month, coming in at also 23%, and once a month or less at 20%, and 4 times a week or more is a paltry 8%. So there's a nearly an even split between 2 to 3 times a month, once a week, and 2 to 3 times a week. So what that means is stop beating yourself up about the number of times you're having sex. It's like everybody's kind of doing something and nobody's really standing out too much, except for the people having sex 4 or more times a week. You are the minority at 8%. And of course, like they've polled their followers. So of course there's going to be bias in this of like people who are maybe interested in sex or improving their sex life are going to probably be the people who are following Vanessa and Xander Marin. But still 54,000 people, you're going to glean some data. So they looked at some data to look at how having kids impacts sexual frequency. So they found very few differences between people who had kids, which was 70% of their people responding, versus child-free couples, which is about 30%. Couples without kids are having they're slightly more likely to be having sex 2+ times per week, but the difference was surprisingly small, just a few percentage points. So like the myth of like, we can't have sex because of the kids is like, maybe you're using the kids as an excuse. What do you think? Next question, does age matter? Surprisingly, age doesn't seem to have a huge impact on sexual frequency either. As age increases, couples were slightly more likely to be in the once a month or less category, but across all age groups, the 3 most common categories remained the same: 2 to 3 times a month, once a week, and 2 to 3 times a week. They did find that those 50 years of age or older were just as likely as those 18 to 29 to be having sex 4+ times a week. You guys, again, we're using age as an excuse. The myth of like, well, now that we're older. I had this couple come in my office. They were like in their mid-40s, and they're like, well, if you're telling us that we can still have a sex life when we're older. And I'm like, I just talked to some 80-year-olds who are like doing just fine. So they may need, some lubrication, some vaginal estrogen, maybe some erectile dysfunction, but they're having sex. So life is good. Doesn't matter if you have kids, doesn't matter if you're getting old. So then they asked quality versus quantity. We asked people to rank their satisfaction with the quality of sex they have on a scale of 1 to 5, with 5 being very satisfied. The most common number was 4, which was 40% of people. And then the second most common number was 3 at 27%. Only 11% of couples reported being dissatisfied with the quality of sex they're having. So there does appear to be a correlation between sex frequency and reported quality. Couples who report being dissatisfied with the quality of their sex tend to be having less frequently, whereas couples who are more satisfied are more likely to be having sex more frequently. This I would put in the category of correlation does not equal causation, right? Like if it's good, you're probably having more of it. If it's not good, you're probably having less. Not like because we have more, it's better. You know what I'm saying? Like correlation versus causation, very important in scientific studies. Because this is how doctors and people get into the like, just have more sex so you'll like it more. And that is not that's not how it works. It's not always the case. Now you might get better at it. You might learn some things, be more comfortable with it, you know, be able to communicate better. All the things that go along with having more sex, right? Might not be as awkward. But telling somebody that they should have more sex so that they'll enjoy it more probably is not the full picture. Okay, next paper. So thank you to Vanessa and Xander Marin for polling 54,000 people. This was an amazing paper. So I just recently interviewed Dr. Justin Dubin, who's a urologist now practicing in Florida. And that podcast isn't out yet. Stay tuned. It's going to come out soon. And we talked a lot about the men's. And he published this paper along with a friend of mine, Ashley Winter, and a bunch of other people. Dr. Winter's also a urologist. So this was published in 2021 in the Sexual Medicine Journal. And it's very interesting. We actually talk about this on the podcast too. The title of the article, and this link is in the podcast show notes if you want to go pull this article, is female wellness affected when men blame them for erectile dysfunction? This has never been looked at in a research study before, so props to them for looking. So their aim of their study was to investigate whether women who are blamed by their male partners for their ED, erectile dysfunction, experience worse overall sexual function and satisfaction. So they basically online surveyed a bunch of people. You had to be over 18, et cetera, et cetera. 13,617 females participated in the survey. Of the women surveyed, 79% have experienced their partner losing their erection during sexual activity, and approximately 1 out of 7 women, so 14.7%, had experienced being blamed by their partner for loss of their erection. Women who were blamed for their partner's erectile dysfunction were more likely to end the sexual encounter, were less sexually satisfied, and were more likely to end relationships due to their partner's ED. So, I'm going to read a little bit more of this because I think it's interesting, so I think you guys might think it's interesting too, but the summary of this is don't blame your partner for your erection issues. Maybe don't blame your partner in general. Like, it's oftentimes not their fault. Women can't make erections go away. Men's thoughts and feelings and anxieties can, right? And then they can get defensive about it and maybe blame their partner, but that will only add to the misery, is basically the gist of this. Okay, so I'm going to read a little bit. Male erectile dysfunction, defined as the consistent or recurrent inability to attain or maintain an erection sufficient for sexual activity, is the most common form of sexual dysfunction in men. A diagnosis of ED is said to affect as high as 52% of the male population, with 5 to 20% of men suffering from moderate to severe ED. ED's prevalence is strongly correlated with increasing age. ED is seen in 15% of men 40 to 50 years old, 45% of men in their 60s, 70% of men over 70 years old. Depends upon what data you look at for that, because I've certainly seen 40% by age 40 as far as some erectile dysfunction. Other variables directly correlated with ED when adjusting for age include smoking, heart disease, hypertension, diabetes, indices of depression and anger and emotional stress. So, what they found is the attitudes of females towards their male partner's ED, including its severity and treatment, have also been strongly associated with the likelihood of the male partner mentioning ED to a doctor and trying a PDE5 inhibitor. PDE5 inhibitors are Viagra and the cousins of Viagra, the brand names being Viagra, Levitra, Cialis, Staxa? There's another one. Can't remember. Compared to couples that do not use PDE5 inhibitors, women with partners that initiate PDE5 inhibitor therapy experience significantly more sexual desire, arousal, and orgasm. Very interesting. Not sure exactly all that means. So, what this study did is they stratified women by age, and the majority of women had experienced a partner losing an erection during sexual activity, and even between the women between the ages of 18 and 29, the rate of erectile dysfunction or losing an erection was 75%. So troubles with erections might be a lot higher than that data that we just cited. Women who were blamed for their partner's ED experienced significantly worse self-confidence compared to those who were not blamed. They also felt an increased sense of strong responsibility for their partner's ED and worried more about their partner's ED compared to those who were not blamed. In addition to their worsening sense of self-confidence, the quality of their sexual encounters was significantly worse. Women blamed for their partner's ED were more likely to almost always end the sexual encounter and were more likely to almost never be satisfied during the sexual encounter. It's just a rough relationship, you guys, all around. In assessing blame's effect on relationships, women blamed for ED were more likely to have ended and were more willing to end future relationships due to their partner's ED. This takes me back. I was a medical student. I feel my brain tells me I was doing it like a neurology rotation or something. I don't remember. And there was a guy who came in, like big, manly man, like way older than I was at that point. And he was worried about his erections. And he said, my girlfriend's going to leave me because of these erections. And I was like this young, naive med student. I hadn't been to urology. I hadn't talked to a lot of people about their sex lives at this point. And I was like, no, she's not. Women wouldn't do that. Women wouldn't leave you just because of your erection. And like, now that I'm 20 years older and wiser, when a guy's like, I'm afraid my girlfriend's going to leave me, I'm like, oh yeah, no, women do. Women do leave men. I say it a little bit nicer in clinic, but like my gist is like, I've been around the block enough now to know women leave people because of erectile dysfunction. And you wonder how much of that is wrapped up in like the socio-cultural situation, right? Like, well, now if 1 out of 7 women is being blamed for the erectile dysfunction, she's definitely more likely to leave. But like, if we can't expand sex to be something besides putting an erect penis in a vagina, when the vagina is broken, the vulva is broken, the penis is broken, like the sex goes away because people haven't figured out how otherwise to be sexual. And I hear it over and over again in clinic. Like, people have great sex lives, not in the like stereotypical, traditional Hollywood penis and vagina sex. So that's why we gotta be comfortable talking about sex. Don't blame your females for your erections too. Let's see, a couple more things on this. We also assessed the role of female sexual desire and satisfaction in the face of ED and the effects it had on the overall relationship. Women who always lose their sexual desire when their partner experiences ED are significantly more likely to end their relationships due to ED. So if you think something's gone wrong, right? Instead of just being like, hey, the body's just not doing exactly what we want it to do, let's change gears. Let's do something else sexually. Let's take some stress off. Let's relax a little bit. Let's maybe try this again in the future without pressure, right? Like, all that can be learned and trained. But if you think something's horrifically gone wrong and or you blame yourself or your partner blames you, you're more likely to avoid sexual activity. All right, so that is an awesome article, and they basically like conclude by saying an important consideration in the role of male blame in female health and wellness is that although blame affects the female, it is actually the male partner and their reaction to their own sexual dysfunction that potentiates issues for the female partner. The majority of the participants in our study were aged 18 to 29, and although we lack any information on the ages of partners, we can assume most of them are under the age of 40. In this younger male age group, the prevalence of ED was 79%, which is high compared to what the data says. They're unable to conclude why the prevalence of ED was so high in their study. And they said, but based upon if we like think that the ages of the men were the same as the women, we can only speculate that most of the ED was due to psychogenic causes like anxiety, depression, anger, and partner-related difficulties. So thank you, Justin Dubin et al. for thinking about this paper and for writing it, because it shows just how rough it is out there, that, you know, relationships are ending over sexual dysfunction. That's my one takeaway. My second takeaway is that the female partner is being blamed 1 in 7 times. That's huge. So I wanted to give a shout out to that paper. All right. Let's switch gears just for a second. And there's this cool little paper in the Urology Journal that I ripped out, just looking at examples of misinformation found on YouTube and TikTok videos regarding urinary tract infections. So this is like the themes of misinformation. This is how bad the internet is, and why again you should not get your healthcare from the internet, because it's wrong. There's wrong stuff there. Okay, themes of misinformation. Theme number 1: things to avoid doing or eating to prevent or treat UTI. Examples: spicy food, drinking too much water when taking antibiotics, the theory that it dilutes the antibiotic effectiveness, baths, wearing tight clothing. So none of those have been proven to hurt. Theme of misinformation regarding UTIs. Number 2: foods to eat to prevent or treat UTIs. This is all that's on the internet, you guys. It's so bad. Apple cider vinegar, that's a huge one. Boiled parsley, cucumber lemon water, fire cider, which is a mixture of horseradish, turmeric, ginger, garlic, jalapeno pepper, and black pepper. Fresh squeezed lemon juice, juiced red peppers, asparagus, lemongrass tea, smoothies made with pear, apple, and orange. At least the last one sounds good. But like, can you imagine, like, your girlfriend wants to hang out and you're like, no, I'm sorry, I have to juice some red peppers to prevent or treat my UTI. Like, where's this coming from? Who's making this shit up on the internet? All the people. Number 3, theme of misinformation for things found on YouTube and TikTok regarding UTIs. Things to do to prevent or treat UTI. Sit and urinate in a bathtub filled with chamomile tea. Soak in a tub of apple cider vinegar and magnesium flakes. You're going to fill your entire bathtub with apple cider vinegar? This is insane. All right. See a doctor or a nurse practitioner or a PA if you think you have a UTI, you guys. Stop listening. You can hydrate and take an anti-inflammatory, maybe some azo or pyridium. But like, if it's bad and you're peeing razor blades, let alone you have a fever, do not juice red peppers. It's not going to help. All right, next thing I wanted to talk to you guys about was this article in The Economist. Props to The Economist. I talked about this a couple weeks ago, too. Like, they are covering sexual health lately, and I'm just impressed by them. So good job, Economist. This was from January 7th, Economist 2023, in the Middle East and Africa section. Sex toys in the Middle East. Women are breaking sexual taboos in the Middle East, which is awesome. I say, even the act, this is me reading the Economist article to you now. Even the act of defiance has to be discreet. On the wall of a private art gallery in Dubai, the raciest city in the United Arab Emirates, is a set of office pigeonholes. They contain photographs of homemade sex toys, mere photographs, because if they were real, Dubai's police might seize them. That they are homemade because importing them is banned. Side note here, this is me now. I'm putting in the mail a whole bunch of clitoral air pulse vibrators to my members, and like the immense privilege I have that I can like freely ship that in America and give people gifts. So you're welcome. This country is more free than a lot as far as sex stuff goes. Okay, in recent years, sexual taboos have been broken across the Middle East. Receptionists no longer check that couples sharing a Saudi hotel room are married. Last year, the United Arab Emirates decriminalized premarital sex. Just last year, you guys. A growing enthusiasm for sex toys reflects women's rejection of the idea that men should control their sexuality. In Dubai, customs inspectors scour the bags of incoming travelers, particularly women of Arab origin, and seize any sex toys. Many are left off with a warning. But under the country's indecency law, they can be fined up to the equivalent of $13,000 and put in prison. Similar colonial-era laws prevail across the Middle East. Every year, customs officers throughout the region confiscate dildos, vibrators, and fluffy handcuffs. Many religious preachers reinforce such attitudes. Most consider masturbation to be haram or forbidden. The leading ayatollahs of Shia Islam have issued fatwas specifically prohibiting sex toys. Sunni scholars also fulminate against them. An Iranian mullah has warned women against peeling aubergines, which is eggplants. So don't peel eggplants, lest it inspire improper thoughts. Self-pleasure is the biggest taboo here, says Christina Lindia, a Finnish sexologist based in Dubai. Can you imagine being a sexologist based in Dubai? Good Lord. It's hard for me to talk about sex on Instagram in America. I can't imagine. It says, and yet some people find ways around the bans. Some lingerie shops in Dubai malls double as under-the-counter sex shops. Online stores offer wellness enhancements. advertising vibrators as electric face massagers. Global demand for sex toys soared during the pandemic. Sexologists and retailers in the Middle East have seen similar trends. A vibrator called Deem goes for $85 online. It is sold out twice. The recourse to sex toys is part of women's desire for greater empowerment, says Sura, the founder of Maj, a website run by Arab women, whose name means wave of sexual pleasure, and which sells Deems. In places like Dubai, expatriates who make up 90% of the UAE's population are accelerating this shift. More open-minded religious figures are also playing a part. Unlike their Christian counterparts, Muslim clerics have long insisted that their religion encourages sex for pleasure, not just procreation. Sheikh Mohammed Fadallah, an influential Shia Lebanese cleric who died in 2010, argued that female masturbation is not haram because no semen is spilled. Dildos make a legitimate substitute, he added, if the husband is absent or unable to satisfy his wife. Others are now making similar arguments. One Sunni cleric from South Africa endorses sex toys if used for foreplay between married couples. Some Saudi clerics say vibrators are acceptable if they are not invasive. New platforms launched by women promote self-pleasure as an act of female liberation. We're tackling the culture of shame that governs our bodies and lives and helping women explore their sexuality head-on. If all else fails, Council's another website. Use your fingers. They're free and aren't banned. So I just wanted to share that because I don't know how many of you guys actually know, like, it's real bad in some places as far as the government having laws over what you can and cannot do with your body sexually. So I hope that was interesting to some people. And thank you to The Economist for giving some attention to that. Next article I wanted to talk about was going back to mindfulness with female sexual dysfunction. This is a article that was published in 2022 in Mauritius, which is a menopause journal. So this is Associations of Mindfulness with Female Sexual Dysfunction. And the first author is R. Sood. And so basically the editorial on this is female sexual dysfunction affects women of all ages. It's often a multifactorial problem with a strong psychosocial component. Mindfulness may help alleviate female sexual dysfunction with non-judgmental, present-moment awareness and decreased emotional reactivity. The goal of the study was to assess the associations between dispositional or trait mindfulness and female sexual dysfunction. So within their sample, 57% of women met female sexual dysfunction criteria, and they said people who had greater mindfulness had associations with higher or better sexual function scores, lower sexual distress scores, and lower odds of female sexual dysfunction. This association persisted on multivariable analysis after adjusting for potential confounders. So I really like this. So basically, it's saying higher traits of mindfulness was associated with better sexual function, lower distress, and lower likelihood of female sexual dysfunction. This stuff can be taught, you guys. You can learn mindfulness. This is not an innate, like, my eyes are green sort of thing. And Lori Brotto out of British Columbia wrote the mindfulness basically the mindfulness and sexual health book for women. I can't see it right on my bookshelf right now, but let's see. No, but it's there. It's on my bookshelf. I had to reach out to her and get her on the podcast, but she's the kind of the big one who wrote the book on mindfulness and basically just teaching women mindfulness and to be present and to be in their body and to let go of distractions. And don't blame yourself for your partner's erectile dysfunction, going back to the earlier part of this podcast, really makes a freaking difference. It helps all aspects of your life. So think about it, work on it. I just got the app Waking Up by Sam Harris. It's incredible mindfulness training app. It's a huge app. There's so much content on there. You get a first month for free, and then I think a year you can get for like $99. So it's like, there's certainly cheaper mindfulness apps out there, but I'm to the point in like my training that I wanted that really high level content that is provided by that app. So check it out if you think that mindfulness might be right for you. If you have kids, mindfulness is good for you. If you have a job, mindfulness is good for you. If you are a human with a mind that thinks too much, mindfulness is going to be good for you. So let's see if I can talk about one more thing before the end of this podcast. Got so much stuff. I'll save the rest of this for next time. The next thing I wanted to share with you was a October 2022 publication in the American Urology Association News. And this was written by Dr. Kling and Dr. Sharon Parrish, talking about the clinical practice guidelines for the use of testosterone in women. Lots of people ask about testosterone. And I usually just refer them to my podcast. Like, I sneak them in, some of these monthly live podcast recordings. So I'll read this one to you because it's pretty darn good. Talks about a lot of different studies. Distressing decreased sexual desire impacts an estimated 12% of women aged 45 to 64 in the United States. Hypoactive sexual desire disorder is a clinical diagnosis that includes recurrent or persistent reduction or absence of sexual thoughts or fantasies and is accompanied by significant distress that is not explained by a psychiatric or general medical condition. While the DSM-5 has combined sexual desire and interest disorders in the diagnosis of female sexual arousal and interest disorders, hypoactive sexual desire disorder is still considered a diagnosis that can be utilized for clinical management, particularly when considering medication treatment. Evaluation for hypoactive sexual desire disorder should include a thorough history that incorporates asking about biopsychosocial factors and other domains of sexual functioning, including arousal, orgasm, and pain, as well as a gynecologic exam and laboratory testing when indicated. The biopsychosocial clinical assessment will assist in the identification, modification, and management of contributing factors and should be done before pharmacology is considered. Yes, you guys, that is why I never give meds on the first date. Like, we gotta talk, you gotta learn about sex first. You gotta learn about biopsychosocial. Ideally, you listen to my podcast or read my book because you're gonna get so much out of that if you then choose to use a medication. If you don't understand any of that and then you just go on a med and then the med doesn't work, then you're a med failure and now you're like doubly miserable. Nobody's happy. So, for premenopausal women with HSDD, 2 U.S. Food and Drug Administration approved treatments are available: philbanserin and bremelanotide. I have talked about those previously on my podcast. While no U.S. Food and Drug Administration approved treatments are available for postmenopausal women with HSDD. However, testosterone, a steroid hormone that modulates sexual behavior, has evidence to support its efficacy in the treatment of HSDD in postmenopausal women. Transdermal testosterone has been shown to improve sexual desire and reduces sexually associated personal distress in menopausal women diagnosed with HSDD, with and without concurrent hormone therapy, meaning estrogen and or progesterone. No testosterone serum level correlates with presence or absence of HSDD or its severity, but there is a correlation between testosterone concentration during therapy and improvements in sexual dysfunction. No serious adverse events has been seen with physiological testosterone use, but there is lack of data showing long-term safety. Potential side effects of supraphysiological testosterone includes hair growth, acne, voice deepening, and alopecia. I would add enlarged clitoris that doesn't get back to normal size. 2 recent position statements provide guidance to clinicians regarding the use of testosterone for the treatment of HSDD. If you go on my Instagram and you go on my link tree, or if you're in my membership, I have links to both to those guidelines, the ISHWISH clinical practice guidelines. So, these guidelines both provide practical clinical guidance, including formulation, dose, and monitoring. Since there are no testosterone formulations for women approved by U.S. National Drug Regulating Authorities, off-label use of approved formulations for men are used for women at approximately a tenth of the standard dose for men. The most physiological form of replacement therapy is transdermal, and intramuscular injections and subcutaneous implants should be avoided since they result in supraphysiologic levels. Oral preparations are not recommended because of possible adverse lipid effects, such as reduction in HDL cholesterol and increase in LDL cholesterol. Dosing should aim to achieve testosterone concentrations in a physiological premenopause range. It's important that patients receive informed consent prior to initiation of treatment, with a comprehensive discussion of off-label use as well as benefits and risks. In addition, baseline total testosterone levels should be obtained to exclude women with mid-range to high values at the onset of therapy, as well as baseline liver functions and lipid panels to assure they are in a normal range. There is no blood level that is used as a treatment target, but a repeat level should be measured 3 to 6 weeks after initiation to assure the total testosterone remains in a physiological range. For women who do not notice improvements in their HSDD after 6 months of use, testosterone can be stopped. And sometimes it does take that long, you guys. I usually say at least 3 months, so 3 to 6 months of use to see desire go up. If it is continued, then annual evaluations should be done that include monitoring of lipids, liver function tests, and complete blood count, as well as breast and pelvic examinations and mammography. Ideally, in the future, U.S. national drug authorities will authorize a testosterone formulation for women suffering from HSDD. You guys, if they did that, it would be so expensive. Using the male dose at 1/10 the dose is going to be the cheapest, even if the FDA comes out with an approved female product. Just saying. All right. So there you go. There's a little nice summary on using testosterone and that there are guidelines and things to follow, which helps. Insurance won't cover it. But again, it's really cheap if you use the Testum 1% generic gel and dose it at 1/10 the dose for the female dose. So that's probably enough sex toys, hormones, all the things for one day. I love you guys so much. This podcast is getting so freaking close to 1 million total downloads. If you're new, welcome. I'm so glad you're here. If you are an original gangster of this podcast, again, thank you so much that you're here. Thank you for everybody that's shared this with their friends or their patients or their students or their sisters. Thank you for the people who go on and give me stars and reviews. It means the world to me when I wake up in the morning and see one. So if you want to be so kind and do that, it really helps increase the rankings under Apple. And I'll see you at 1 million. We're so close. I love you, and happy 2023.